Just loading. Hello, everybody, and thank you so much for joining us for another episode of Empowered, presented by Cancer Warrior Canada Foundation. If you don't know me yet, my name is Rebecca Durrance-Hein, and I am a cancer thriver, founder of Arenda Cancer Community and blog, and now your host for this evening. I want to encourage you to participate in tonight's episode by posting any comments or questions that you might have in the comments section below the stream. And we're going to, just like with the other episodes, we'll talk for about 35 minutes or so, and then we'll have 10 to 15 minutes at the end where we address any audience questions that have come in. Our empowered guest tonight is Dr. Geeta Kadyapat. Dr. Geeta has been associated with surgical oncology for the past 15 years. Although she has gained valuable experience in treating a whole range of cancers, she has a very special interest in breast cancer and breast surgery. She's actively engaged in performing the entire range of surgeries recommended for breast cancer, including modified radical mastectomies, breast conservation surgeries, and oncoplastic breast conservation. She did a fellowship in the breast unit of the largest cancer center in the UK, Royal Marsden Hospital in London, from 2003 to 2004. And she aims to make a difference in the lives of her patients suffering from breast cancer by providing comprehensive services that are targeted not only at their treatment, but also their rehabilitation, which is so important. She currently runs the breast clinic at Max Super Specialty Hospital in India, where she has been the head of breast surgical oncology since 2014. Welcome, Dr. Geeta, and thank you so much for being with us here tonight.
Thank you, Rebecca.
You're welcome.
I'm so glad to be here.
Wonderful. So why don't we get things started? Will you give us a little bit of background information about yourself and maybe how you came to focus on breast cancer specifically in your work?
So it all started, I trained to be a surgeon in the late 90s, and it was in 2001 that after my fellowship from the Royal College of Surgeons at Glasgow, that I got into surgical oncology. So it was not a choice decision, but it is just that something that I wanted to try my hand at, and finally my mentor and guide, Dr. Chaturvedi, he said that you have to find a niche space, because you have to create that space, because in India, surgical oncology was also pretty new at that time. It really started off as a branch in the 90s. And then he said, you should look at a specialty. So I said, okay, specialty. So in India, women like to go to women. So it seemed like breast cancer seemed to be the natural choice. And that is when he encouraged me to go for a fellowship abroad. And that's when I landed up in London in 2003. Wonderful. And when I came back, I joined a full-fledged cancer center. It's a large cancer center in northern India, which is called Rajiv Gandhi Cancer Institute. And I was there for 5 years. Although I was doing a lot of other surgical oncology, but my heart was in breast cancer all the time.
Yeah.
Then I moved to this corporate hospital that I work in currently. That was in 2009. I'm associated with that same organization called Max Hospital in Delhi, which has got several hubs within Delhi and outside. And then, of course, I was able to pursue just breast cancer. So we've got disease management groups, and breast cancer is also one of those disease management groups. And I happen to lead the breast services is in one of those hubs in Delhi. Yeah, so wonderful. That is my breast cancer journey. So it's about 20 years now, Rebecca. Wow. So, you don't you don't realize how time flies, but it's been 20 years since I've been right?
Well, that's wonderful. It sounds like you have just extensive knowledge and background. That's wonderful. So let's get right to it. So you talk about non-modifiable risks and modifiable risk factors when it comes to breast cancer. So what are some of these factors, and maybe what's the difference between those two categories of risk?
Yes. So when we talk about breast cancer, the first question somebody asks you is, why does it happen? So my usual answer is, the why is still not been answered completely, because had we known why, then we would have known what to do completely to get rid of it. Mm-hmm. So when we talk of breast cancer, we talk about risk factors. So when we say modifiable and non-modifiable risk factors, so the non-modifiable risk factors are those which you cannot change. I think the biggest risk factor is just being a woman. being a woman, it's the biggest risk factor, because if you see, 99% of breast cancers happen in women. It's only 1% that happens in men. But then there are other things in your own persona, which is, the family that you're born into. You can't change that.
Right.
Your personal history, in the sense, your menstrual history as to when you start menstruating, when you stop menstruating. So these are all non-modifiable risk factors. You can't do anything to change these bits. But the modifiable risk factors is where you can change quite a few things. So in your personal thing, there are risk factors, like they say, if you were to have kids early, they're supposed to be protective. If you were to breastfeed, that also seems to be protective. But if you ask me, in India, the breastfeeding bit is not true, because in the data that we looked at, about 80% of our women who had breast cancer had breastfed. So we don't find a correlation. So I think it's purely incidental or coincidental that breast cancer and breastfeeding has been put together. Then there are other risk factors which you can modify, is your lifestyle, because breast cancer is by and large a lifestyle disease. So what you eat, how do you look after yourself, especially those ladies who are kind of overweight, obese, they tend to have a higher risk of having breast cancer. Then alcohol is again a risk factor, because now WHO says no alcohol at all. From very little, say one or two drinks a week, to no drinks at all is what is the recommendation now. But then, yes, I always believe that everything in moderation is fine. It is when you overdo things that it comes back to hurt you. So physical activity is again something that is something that you can all really work on. And we see that those women who've been exercising as a routine in their lives before they get the cancer, and even after they do, they tend to do better. So it's a thing about exercise. Then what you eat. So I always say that the coronavirus has only reinforced and driven this point home, that eating at home, doing fresh food every time is probably the way to go, because that ensures that you're not having a lot of the junk food that is freely available, tastes very good, but doesn't do good for your body.
No. Yes, it is. And it's too readily available these days.
Yes.
Yeah, and it's just full of, as you say, sugar and bad fats and all sorts of stuff.
Absolutely. Absolutely.
Yeah. So I know for me, when I was, before I was diagnosed, I always really assumed that, and I don't know where it came from, but I think it's an assumption a lot of people have, that cancer is primarily genetic, or that at least genetics plays a much bigger role in your development of cancer. So how much of a factor do genetics play in the development of breast cancer? Because I was surprised. I always thought it was more.
Yeah, so it's only about 10%, 5 to 10%, and stretch it a bit more, maybe 15, but not more than that. So this is a very common question which patients put to you, that I don't have anybody in the family who's got breast cancer, and how did I land up having breast cancer? But you must know that about 80 to 90% of breast cancers happen in a sporadic manner, which is not hereditary. Of course, there is a mutation that happens at the genetic level to give rise to cancer, but genetics is only about 10%, 10 to 15%, not more than that.
Yeah. So, because as you say, I think a lot of people think, oh, well, no one in my family has had breast cancer, so, I'm probably fine. There's not much that I can do about it. And I know that, for me, as I was 28 when I was diagnosed, and my surgeon was quite sure that I was going to have a genetic predisposition, BRCA1 or 2, and I didn't. And I think that was very surprising for a lot of people, and myself too, right? Because then you think, okay, well then how did it happen? So and I think it's sort of a dangerous assumption or mentality, because then we don't necessarily do all the things that we could be doing to help prevent, to help lower our risk. So now that we know, genetics only play a small a smaller role in the development of cancer. What are some of the other things that people can do to lower their risk of developing breast cancer?
So like I said, obesity is coming up as one of the main, reasons, because the more amount of fat that you have, there is more inflammation, and there is more chances of constant inflammation giving rise to cancer. So I think these bits are something that one can take care of. So for me, lifestyle, what you eat, and the exercise bit really forms the core of what you can do to prevent it from happening.
Right.
Then, of course, there is something called body awareness. Although I would say that probably the West and Canada and the US, and where there is a good screening protocol, you tend to find these diseases early, which is very unlike what happens in my country, where there is unlikely to be a huge screening program, because we are a huge country of 1.3 billion people. So unlikely that we would get to that, because it's a lot of resources that go into having regular mammograms. And so for, I still believe, although there are a lot of people who would say that, breast self-examination is not a great way to screen people. But in a resource-poor country like ours, where, mammogram is kind of out of the question for most women, breast self-examination is a good fallback mechanism, because, you need to be familiar with your breast. So, Rebecca, you 28, I don't know how you picked up your cancer, but I'm sure familiarity with oneself helps pick up cancers early. So in my country, the challenge is, because most of the cancers are detected late, even today. So 50 to 60% of your breast cancers would be locally advanced breast cancers or metastatic breast cancer.
Yeah.
So there, the challenge is to bring a tumor or a cancer which is stage 4 to a stage 2 and a stage 3 to a stage 1. So that is the challenge. So that challenge can be overcome to a large extent if you're body aware. If you were to, examine your breasts on a regular basis, and, if you could have a lumpy, bumpy breast, but that's you, that's your normal you. But if something were to crop up in the background of that lumpy, bumpy breast, you would know, provided you were familiar with your breast. It's like traveling on the same road every day, because if you're traveling on the same road, you know exactly where the speed breaker is, where the curb is, where the turns are, or the twists are. So you know what to evade, and you can actually be blindfolded, and then you would be able to say, well, this is what is going to happen. So I think that is where it is important to be self-aware.
Yes, I really like that analogy. Yeah, that's great. Yeah, I mean, I found mine on my own, but it was almost accidental. I never did like proper self-exams, but I did know that, it was good to get to know what your breast felt like normally, so that, as you say, you could notice when something changed. But yeah, so for me, I wasn't doing them really regularly. I would just kind of have a feel around every couple of months. So I got really, really lucky just in the positioning of where it was. It was right on the outside. So it was quite close to the surface of my skin. So I was just very lucky in that where it was very easy to feel. But that's not the case with most. That's right. Most start, I believe, closer to the center of the breast tissue, correct?
No, the commonest site would be the upper outer quadrant, but then the areas that cancers can hide is the lower half of the breast, where your hand generally doesn't go to. But Rebecca, you're an exception. 28 years, we don't see so many cancers in 28, and I would not want our young girls and young women to worry too much about lumps that come up at that age, because every lump that comes in the breast is not cancer.
Yes.
So you would, at your age, I would say about 95 to 99% of lumps in the breast would be non-cancer.
Yes.
It's only about 2 to 3 or maybe 4% of patients who would come up with breast cancer that young.
Yes.
So, but then, having said that, I would still say that women your age should also be breast aware.
Yeah.
Everybody's so caught up in the idea of living life that they tend to forget that your body needs to be cared for
Yes.
earlier than later.
Yes, and I think that is a downfall of the young, is that we tend to think that we are indestructible, and we
don't even
like
think
thinking.
about it. Why should
Yeah,
we
we
be
don't want to
thinking
think
about it?
about it.
I would say, why would a young 25, 28-year-old think cancer?
Right.
It does not feature in their list of things, I'm sure.
Yes, yeah. But as you say, yes, I think it is quite important to still get to know what your breasts feel like, so that, yeah, if there's any changes, or even down the line, right, when you get older,
Yes.
you're still quite aware. Yeah, that's great. So are there, for those of us who have had breast cancer before, is there additional steps or something different that we should do to reduce our risk of recurrence, or is it sort of similar to what we were discussing?
So once you've had breast cancer, again, the focus should return to your body. You have to listen to your body and feed it the things that are good for it.
Right.
Like I always believe that everything in moderation is good. Overdoing anything, you have to eat to be able to live, but you don't have to live to be able to eat. So you have to do everything in moderation.
Right.
And everybody's moderation could be different, but I would say that whatever lets you maintain the correct body weight, your metabolic rate should be good, which can be obviously be improved by exercise. So these are the things that you should focus on even after you've had breast cancer. And physical exercise, like I said, it could be anything. It does not have to have a certain pattern to it. You could be doing yoga, you could be doing aerobics, you would be doing walks, runs, whatever is your thing.
Right. Is there a certain amount of exercise that people should be doing a week? Is there like a recommended amount specifically for breast cancer?
So it's true for all cancers. If you can do 4 to 5 hours a week, that's very good. That's excellent. Okay. Yes, of moderate activity, moderate exercise. That's good enough.
Good.
Yeah.
I just want to remind people at this point to make sure you're commenting and asking any questions that you have, and we'll get to them soon. So for me, as we've mentioned already, I was 28 when I found my lump, and I was very... my family doctor described it to me as winning the lottery in terms of finding it, and finding it when I did. I, as I said, just sort of happened to find it almost accidentally, and it was, I was very lucky that it was still stage 1 when I found it. Primarily, I think, because of, as I said, the location of it, and that I was quite, quick and proactive about going to the doctor. And as we know, we would all prefer to be, if we're going to have a diagnosis, we would prefer for it to be an early stage diagnosis as opposed to a later stage one. But unfortunately, as we mentioned, quite a lot of people are diagnosed in the later stages versus the earlier stages. So why is an early stage diagnosis of breast cancer, or any cancer really, why is that so important?
So when we say early diagnosis, there are, like, for all cancers, it's a beautiful story. You look beautiful, Rebecca.
Thank you.
I really love those pictures.
Thank you.
It's so much of strength. I honestly believe so much in the strength of the human spirit, and you are a complete embodiment of that. It's very, very encouraging to see young women like you who can put these things behind you and move on. Excellent. So you said, why should early detection be such an important thing? Because when we talk of any cancer, we talk of stages of cancer. Beside the stages of cancer, there is something called biology of cancer also. But for in the larger sense, if you detect a breast cancer early, the treatment is so much more easier, and the outcomes are so much more better.
Right.
So I would say that early detection is the key to overcoming the disease and going on to live your normal, natural life. So early detection is absolutely of paramount importance in beating this disease.
Yeah. Yes, and yeah, because I think it's quite true that the not just the sort of emotional and mental toll is, I think, a lot harder, but also, as you said, the physical toll, right? The treatments and surgeries and things like that are so much more extensive. So yeah, if we can find it early, that's just so important. And I know when in terms of early detection or detection in general, you talk about sort of a three-pronged approach or three-step approach. So could you explain what that approach is for people and how we can best detect breast cancer early?
So we call it in our medical parlance, we call it triple assessment. So when we say triple assessment, this essentially means clinical examination, meaning a doctor feeling and trying to figure out what this lump is about. The second thing is imaging. By imaging, we would mean a mammogram in women who are older than the age of 40. Or if on clinical examination, there is a suspicion that this doesn't feel right and you want to do a mammogram, you can do it even after the age of 30. But under the age of 30, there is no recommendation to do a conventional mammogram. Then you have to fall back on other mechanisms of diagnosing it. But then ultrasound breast is a very good complement to mammograms. And for younger women, an ultrasound does give you more information than a mammogram would. So that is the second bit of the triple assessment. And the third bit is you have to make a diagnosis based on the tumor cells or tissue. So the recommended thing again here is a core biopsy. It's a needle biopsy which gives you tissue to be able to determine what is it that we are dealing with. So these are the three arms. So now if you were to not have a very high clinical suspicion and your mammogram doesn't show up much, but I would still say you must go with the third step because you can find something to the contrary at either of these three steps. And if the clinical examination says, you think it is a suspicious lump, your mammogram doesn't pick it up, you should not be going back and sitting at home because the third step still becomes very, very important, and which is a core biopsy. So if there is discordance between one or two, it doesn't mean that everything is fine. In our country, a lot of times you do not have access to a core biopsy. A lot of people end up doing FNACs, and the sensitivity and specificity of the FNAC may not be as high as it would be with a core biopsy because FNAC is very operator dependent. And if you don't have a good cytopathologist reading those slides, you can miss the diagnosis. So it becomes very, very important to remove the lump in that case.
Right.
If the index of suspicion is high, you don't have access to a core biopsy, then it is good in places who are ill-equipped to deal with that situation to remove that lump and see what it is, because it is better than not dealing with that lump at all and letting it grow.
Yeah.
So this is for resource-poor settings because I belong to a relatively resource-poor country. So we have to look at these options of even removing a lump if there is no access to a core biopsy. But in a corporate hospital like mine, we would continue to stick to the triple assessment pattern of diagnosing cancer.
Yeah, and just for just to reinforce what you said, my doctor sent me for an ultrasound first, and it was inconclusive. They said maybe suspicious, we're not sure. So we did a mammogram, but the mammogram was negative. So then my family doctor was very wonderful and trusted me, and she said, well, you know what, let's do the biopsy anyway, just in case. So very glad that that did happen. So that was exactly the situation that you described, is exactly what my situation was in going through all of those.
So in your situation, if there was a suspicious lump, ultrasound showed up something, mammogram did not, which would be the case because a dense breast mammogram just doesn't give you any information. I would have probably even done an MRI of the breast, because in young women between under the age of 30, MR mammogram could be the tool which would pick up abnormalities much better than the other investigations.
Yes. Interesting. Yeah. So so then we'll just shift just a little bit here, but if we're because young women, as you said, are not going to be eligible for a mammogram, and they're not getting regular, they're not getting any sort of regular screening because of their age. So then you mentioned a breast self-exam, and I think that for a lot of women my age or younger, or even, just younger than 40, a breast self-exam, I think, becomes an important tool in the early detection toolkit. So what's the best time and the best way to do a breast self-exam? Because I know that I was never really taught how to do it properly, and it wasn't until after I was diagnosed that I actually started doing them properly. So it would be great, I think, for women to learn how to do it so that they can do it now before they're diagnosed.
So I would say the best time to start doing a breast self-examination is after the age of 20. There's no harm in learning something as innocuous as a breast self-examination. It's good to be familiar. The earlier you learn it, the better. And the timing of doing a breast self-examination is a week after your periods start. Because before the periods, your breasts tend to be heavy, and there's a lot of salt and water retention. There could be cysts, small cysts meaning fluid-filled sacs within the breast, which can actually become bigger and painful. So that may not be the right time to examine, and you can come up with a lot of new things and get worried. So the best time to do it is a week after your periods start, or 2 to 3 days after your periods stop, because then the breast is very soft and pliant, and that is the time to do a breast self-examination. For those who have stopped having their periods, are menopausal, they can fix a date. It could be the first of every month. It could be a day which is coinciding with your birthday, and you could do a breast self-examination every month. The key is every month, because every month means you're going to be familiar with your breast and you would know exactly what's happening.
Right.
And I have a little dummy here. We do something called a touch, feel, and do workshop back here with a lot of women in corporates and in residential areas, in less privileged areas, just to show them what is the right way to do a breast self-examination. And the best place to do a breast self-examination is probably when you're in your bathroom taking a wash. If there is a mirror, you can raise your arms and see. You can see some things, which can give you a clue as to what is happening. So one is just stand in front of the mirror, raise your arms like that, and see what is the level of your nipple. Is the level of the nipple the same? There could be some discrepancy in the size of the breast, which is very, very natural. Then you should be looking for any dimpling of the skin. Is there any indrawing of the nipple? Is there any change in the skin of the breast? So there is something called an orange peel appearance. I would not like to see people getting to that stage, because an orange peel appearance of the skin is actually an advanced stage of disease. So we have this little dummy which we get people to feel, because a lot of people ask you, what is it that I'm supposed to feel?
Yes.
So so they're completely in the dark. We do these lectures and they just go back thinking, oh, what does that lump thing mean?
Yes.
What am I supposed to be feeling? So I'll just show you one bit of the dummy, which
great.
Looks like this. Yeah. So let me just get you into the picture. Yeah. So that's the dummy that we use for our patients. Yeah.
Great.
So you have to do it in the sitting or standing position as well as while you're lying down.
Right.
So we've used this dummy quite a bit. So it seems to be a little flattened out, but yeah. So let me get it. Yeah. Yes. So what you need to do is you could divide the breast into, 4.
Okay.
Or you could do circles around the nipple, and the whole idea is to make sure that you cover the entire breast.
Right. Yes.
A lot of time people do this and think that breast self-examination is
done.
over, but it is done. And you just live in this false assurance that I'm done, but that's not the way to do it. The important thing is to cover the entire breast and this lower bit and the central bit as well. So I would say, if you were to divide it into 4, so these are the quadrants of the breast: the upper inner, the lower inner, the lower outer, the upper outer, and the central quadrant. So if you were to start examining, just use the flat of your hand. Don't use the tip of your fingers to poke the breast, and don't try and hold your breast like that, because you hold it, you'll find something.
Yes.
you will always find something. Even your normal breast tissue would feel like a lump,
Lumpy.
especially the young breast. It
Yes.
could feel like that. Okay. So what you need to do is, let me get this into the center. Yes. Okay. So if you were to start off, make sure that you keep the flat of the hand like that. Your tips tend to be very sensitive, so don't use the tips, just the flat of the hand. And do a slight rotation of the hand like that. I would not do this and then go there, because then you're missing this strip of
Right. Yes.
tissue. You could be missing something there. So just don't move your hand too much. Just slide and rotate, slide and
Okay.
rotate. So you're doing this in the upright position. Okay. So when you're doing it in the upright position, and then go down to there's a lot of things hiding in the inframammary
Right.
crease.
Yes.
Okay. So just do that. Don't move your hand too much. And then you can slide your hand under the armpit as well, because
That's important.
armpit is
Yeah.
where the lymph nodes are. And that is where you could have something there. You may not always find a lymph node because it's something that the doctors usually land up finding, but
Right.
not the patient. So you just need to do that. And once you're done with all 4 quadrants, slide and rotate, slide and rotate, slide, slide, rotate, slide. Don't move the hand around too much. And then the central region, because you could have something hiding under the nipple as well. So that is the way you have to do a examination. Then the other thing that you need to do is, once you're done with doing it upright with little pressure, lie down and do the same procedure again in lying down position, and apply slightly more pressure than you would when you're sitting up, because lots of times there could be lumps which are closer to the chest wall. Like you said, Rebecca, yours was on the top, closer to the
Yes.
skin. It is much easier to find. The
Yes.
difficult ones are the ones that are closer to the chest wall or in the middle of the breast tissue. So apply like little more pressure, so that you're able to get to the chest wall and figure out if there is something that is hiding there. So that is how you would do a breast self-examination, and you should do it every month, like I said.
Yes.
Yeah.
Yeah.
So we use these dummies, and we have